Hi, everyone. Thank you for coming to tonight's Grand Rounds with Dr. Dakkak. If anyone has any questions throughout the talk, please feel free to type them into the Q&A box at the bottom of your screens or save them for the end, and we'll get to them at the end of the talk. Now, I'd just like to introduce our speaker for tonight. MaryAnn Dakkak, Associate Program Director at Boston University Medical Center, Department of Family Medicine, provides full-spectrum family medicine, including surgical, obstetrics, inpatient medicine, and outpatient primary care. Trained at UCSF School of Medical School, followed by Santa Rosa Family Medicine Residency, she also holds a master's in public health from Harvard University. Prior to clinical medicine, she practiced public health, having worked in over 16 countries. She continues to work in public health with organizations such as Partners in Health and Move Up Global. Her academic interests are in disparities in health, obesity stigma, social drivers of health, and LGBTQ plus medicine. And with that, feel free to take it away, Dr. Dakkak.
Hello. So I am talking from Boston. I don't know where everybody's located, but that's where I am. It's a beautiful day today. The weather is just perfect the last few days. And I'm here to talk about something that's very close to my heart. And on the next slide, you'll see the article that I wrote that prompted this Grand Rounds. So I'm just going to go right to my article. So this was an article that I wrote about my experience about 2 years ago with having what ended up being a spinal cord injury that was essentially dismissed because I was a postpartum obese mom. And they just kept telling me this is postpartum pain. And I remember one of my internal medicine doctor friends told me, there's never a reason not to feel your leg because of postpartum pain. Like, that's not a thing. And how the stigma can just become so internalized that we shut off our own symptoms and normalize it because of our weight. So this article was my personal story and what I went through in fat stigmatization, being stigmatized, and then talking about how, as a residency associate program director and as a medical student assistant professor, it's really one of my jobs to educate to patients about weight, patients about and what are effective ways to do that. So the goals of this talk are understand the scope of weight loss goals in our patients, understand how obesity bias affects patient care driven by both patients and physicians, understand the pitfalls in weight loss strategies, learn how to open the discussion with patients, develop patient-centered functional and health-related goals that may or may not involve weight management, and review some of the evidence-based medicine around weight loss. So just some basic stats. Who is even trying to lose weight in the United States? About half of the population is. 56% of women, 42% of men. Is it the, quote, right people? Higher income adults are more likely to be trying to lose weight. 2/3 of adults with obesity, 1/2 of overweight adults, and 1/4 of normal or underweight adults are also trying to lose weight. Yo-yo. I was laughing when I put the slide together because my husband is a musician and is not a fan of Yo-Yo Ma. So when I put this up, I was like, that's just funny that he would say there's a lot wrong with it. No, he actually loves Yo-Yo Ma. He just has a different way of doing music. Anyhow, the biggest issue with dieting, losing, gaining weight, losing, gaining weight, losing, gaining weight is you actually damage your metabolism in very quickly. It's not the long run. It happens actually fairly quickly. Over 80% of people with obesity who lose weight gain it all back. The resting metabolism slows with weight loss, whether it's fast or slow, and it remains slowed with weight gain. On average, burning 700 fewer calories a day than before weight loss began. And that is huge to talk to patients about, because many of my patients who struggle with weight will come in and say, I'm eating less, and I still can't lose weight. And indeed, we have that data that after they have been gaining, losing, they are burning less calories a day. And they can't eat what a person who's never had a slowed metabolism eats and, quote, get away with it, because their metabolism just is slower. What diet works? And this is talking about food diets. So other than low fat, which blanketly doesn't work, all diets work and all diets don't work. So in specific patients, the low carb diet, keto diet, South Beach diet, all of these can work. Weight Watchers can work. Patients have usually tried 2 to 3 diets before they find one that works. Food tracking usually helps. In the long run, however, almost none of these work. And diet without behavioral health, comprehensive medical assessment, and ongoing support most often fails. And interestingly, and this is something that I think is really the crux of how we need to talk to patients about weight, is that weight itself as a goal is not successful. Having functional goals, medication goals, let's say the goal is to, decrease your diabetes medications or decrease your hypertensive medications, actually having a functional or medical goal tends to be much more, well, weight as a goal is not effective at all. So having functional goals is more effective in helping patients kind of keep another goal in mind. Now, this is, I think, the crux of what we need to do when we talk about obesity medicine is we need to do both of these equally and all the time. We need to fight obesity stigma with our normal weight patients who want to lose weight for different reasons that don't usually affect mortality, as well as our patients with obesity who have been struggling with the stigma all of their lives. And at the same time, we can't deny that adipose is a metabolically active tissue that does increase risks of many diseases. So we also need to decrease the morbidity influenced by obesity. And I use those words on purpose. It's not caused by obesity. There's no causal relationship, but it is influenced by obesity. So this was in response to my article. I got a few comments. Actually, the first 4 comments were, "You're not taking obesity seriously." And my response to that has been, I actually take obesity very seriously. Just any time you talk about it in a stigmatizing way, you're actually increasing obesity. And that's not an evidence-based medicine modality. People who internalize weight stigma are more likely to regain weight and have more difficulty in losing weight. And when weight is the ultimate goal, patients are less successful at weight loss or maintenance. So using weight as an ultimate judgment of whether somebody is healthy or not, one, is just not true, because we know that people can be healthy at different weights. And 2, it doesn't actually lead to any weight loss or any weight loss maintenance. So obesity stigma decreases access to care, both by the physician and the patient. If the patient is obese, the provider has stigma, the patient doesn't feel comfortable, the patient avoids care, the patient has more stress, they have higher cortisol levels if they feel stigmatized, they adhere less to medications and recommendations, and they can have increased weight due to that feeling of stigma. Also, the provider can have biased decision-making, which we see again and again and again, which I'll get to a slide about that. And both of those, whether it's patient reaction or provider not providing the correct tests, affect patient outcome in deleterious ways. So physician stigma. I have a whole list of references in the back, but in this great study that was super sad, physicians were more likely to find patients with obesity annoying, difficult, wasting their time, non-compliant with recommendations. They were less likely to order diagnostic imaging. They were more likely to delay surgical care. And physicians over-reported having discussions about weight management strategies, whereas patients felt like their weight wasn't discussed in any significant way at all, and that they were just told to lose weight. And most importantly, this leads to delayed diagnoses and worse outcomes for patients. This is something that I do with my residents and medical students, is I will take a patient that I think might invoke an image for them, and I will read the one-liner or read a few statistics on this patient, and I'll just have them sit and say, how do you imagine this patient looking? How do you imagine them living? What are the assumptions you're making about their life decisions? So I had a patient recently, BMI of 44, sleep apnea, diabetes. And so I had my resident and medical student think, what do you think about this patient? BMI is 44, sleep apnea, diabetes. What do you think they're doing at home? And we talked all about the negative things you could think of, like, oh, are they eating the right foods? Oh, they eat out too much. Oh, they must not know. And the data shows that medical students and residents and attendings still blame a lot of obesity on poor decision-making and ignorance, which we know is actually not true. And getting through those assumptions and then introducing them to the patient often helps them deal with their own biases. And then none of us are excused from how society tells us to look. And so we also check in with, what are your own biases about the way you look and the way you think about your own size? And I don't ask residents or medical students to tell me out loud any of that, but the way that we have internalized our own body image often affects how we subject other people to the same type of notions. And I have a great story. I have a colleague of mine who called me after my article came out, and she's a family medicine doctor. And she goes, for a long time, I thought I was thin because I made smarter decisions. She was like, I was a runner and I ate healthy. And she goes, I've had children now for 7 years. I haven't run for 7 years. I've been eating junk food for 7 years and I am still skinny. And we were just laughing about how we really do get stuck in this socialization that skinny people are smarter and make better decisions. And that just doesn't pan out to be true. So checking in with those biases before we see these patients is important. So blame and obesity, cause versus a risk factor. We think of many diseases are affected by obesity, but again, they're affected potentially by obesity. They're not caused by obesity. While studies show that patients with longstanding obesity from childhood have higher risks of diabetes, CAD, and some cancers, longstanding obesity is only found in 31% of those people with diabetes and only 22% of people with coronary artery disease. So it's not sufficient nor necessary to cause those diseases. And then choices versus biology. There's multiple twin studies that show that genetically people who tend to be skinny tend to be skinny. The biggest risks for obesity are socioeconomic status, genetics, stressors, cultural nutritional differences, many of which our patients can't really control. So just going into that room, understanding that the patient has probably already dealt with stigma, they already feel like they're making poor decisions, they feel a little hopeless, and how we talk to them really can shape how they can start to think about their health in a different way. So should you talk about weight? And my primary answer is kind of no, but then kind of yes. Again, weight as an ultimate goal has poor prognosis for weight loss and maintenance of weight loss. In the context of health problem management and functional health, discussing weight can be helpful. Discussing how weight can be a risk factor for current disease processes versus causal to disease process is much more helpful. So not making a patient feel guilty for causing themselves diabetes or causing themselves hypertension because they're fat, and never say that, will not help anything move forward. So really talking about adipose tissue is metabolically active and it can be inflammatory. And so if you have arthritis, fat cells can cause more inflammation, and help them understand how those cells work, instead of just putting labels on their disease processes that aren't really accurate. So how to start the discussion? More and more, the Society of Endocrinology, family medicine, internal medicine say, ask permission. Ask permission to talk about their weight. If they want to talk about their weight, they might not want to talk about their weight, and that's okay. Sometimes I don't bring it up at all. And I really just let the patient's goals decide what we're going to talk about. Have a context. I think most of my successful conversations with patients around healthy decision-making come out of something that they have already stated is a goal. They want to take less medications. Okay, what can we do to possibly decrease medication burden? They have pain and they want to decrease their pain. What are things we could possibly do? And then I do a lot of mom, baby, newborn care. And I have a lot of moms who come in and they say, you know, I never cared about my health, and now I have a baby and I want to make sure I'm here for longer. And I use those functional medical goals to introduce some concepts of healthy living, healthy eating, etc. Be realistic. My patients with obesity love the fact that I sit down and I go, this is a part-time to full-time job to lose and maintain weight loss. It is not easy. It is not your fault. Fat cells beget fat cells, and they do not want to lose themselves. So as soon as you are overweight or obese by those numbers, your body will want to maintain that slower metabolism, and it will be very difficult to speed it up. I acknowledge that the benefits of health are often achieved with very little weight loss, but increased activity and increased healthy eating. So even if we don't weigh anybody, just by improving physical activity and healthy eating, we can improve health outcomes. And then I get a lot of patients, because I do a lot of women's health, who want to lose weight when they're actually normal weight or slightly overweight, in which there's no morbidity and mortality benefit. And in those situations, I talk about stigma and I talk about body image and how they feel about themselves, and really work on getting healthy body images to our patients who really. And then this is something that I obesity medicine is, you know, we have patients who get a gastric sleeve, go on the obesity medications and do incredibly well. And then we have a subset that really had a poor self-image to begin with that begin to really not do well. And acknowledge that weight loss will not solve issues of body image, will not solve issues of body shame, food disorders, and can really worsen those. So really checking in with your patient and see if this is even something that they're interested in, you know, thinking about, because it could actually be dangerous to them and their mental health well-being. So this, I love this article. This was in Cell, it's from 2021. And it's, what if you just didn't talk about weight at all? Weight loss versus just increasing fitness and physical activity. And essentially, they showed in huge data sets that the mortality risk associated with obesity is largely gone once you eliminate, once you have moderate to high levels of fitness. So essentially, and I'll get to the graph below, just focusing on fitness could attenuate any effect of obesity. Weight loss, even if intentional, is not consistently associated with lower mortality risk. All the cardiometabolic risk markers associated with obesity also decrease just with fitness alone. And increased physical activity is consistently associated with greater reduction in mortality than just weight loss. And then, as we talked about, weight cycling is actually very dangerous to patients and can increase morbidity and mortality. So this is kind of, and we have so many patients who fit into this. They desire weight loss. They have multiple weight loss attempts. They fail to maintain their goals. They get frustrated. They regain, and obesity prevalence goes up. So this is a cycle that many of our patients go through before they even get to the door to meet us. And how do we kind of hold them in that spot that, yes, this is very difficult. And then how do we refocus them on some health goals that they can actually get to? So this is, again, the physical activity is a more important indicator of all-cause mortality than weight. So as you can see, the red are people who have moderate to high activity scores, and the blue are low activity scores. And the top is all-cause mortality, and the bottom is cardiovascular disease mortality. And as you can see, there's no significance in moderate to high activity patients in all-cause mortality whatsoever. And it's really being sedentary and not having any physical activity that's the highest risk. So I have 3 cases just to talk about, and one of, these cases all have given permission to share them. The first one is me. So I was 40 years old when I had my spinal cord injury. I had a BMI of 37. I've been overweight since adolescence. I had no comorbidities, no diabetes, hypertension, hyperlipidemia, no OSA. My father has hypertension and hyperlipidemia. I didn't come in for weight loss at the beginning. I actually had my spinal cord injury, had surgery, and then because my left leg just continued to be weak, I couldn't be as active as I used to be. I went to the weight loss clinic just so that I could be more active. And so that's what brought me into weight loss. And I got kind of exactly what I put into it. My goal was never to be a size 8 or 6, or, it had nothing to do with that. It had to do with, I wanted to hike again, and I wanted to bike again, and to be able to do those things without having more weakness in the left leg. And I had my surgery, I think like 5 months ago, and I'm already biking again. I'm already hiking again. And it's been exactly what I wanted it to be. People ask me like, exactly how much weight have I lost, or like, and I don't even really care. I just care that I'm able to do the functions I want to be doing. And that's kind of how I prioritized it. The second case is one of my dear patients who's actually makes a cameo in the article herself. So she's a 38-year-old woman, a BMI of 44, height of 6'2". So this woman is overall just a very large woman. She's been big since a kid. Her whole family is big. They're all super tall, super broad. She's very active. She's actually a director of a local YMCA. She does, however, have a very strong family history of diabetes, hypertension, hyperlipidemia. Currently, she only has OSA. And for the first 1.5 years that I knew her, she never brought up weight, and I didn't bring up weight with her either. And then this 44-year-old woman, who's also one of my dear patients, BMI is 26, no comorbidities, wants to lose weight. And she starts with, I really want to lose 10 pounds. I really just want to feel good about myself. So going back to this slide that I really find is important to me in my conversations with them, I want to fight obesity stigma because that doesn't help anybody. And I also want to decrease the morbidity influenced by obesity. So starting at the bottom, this 44-year-old woman doesn't have any risk factors that I would want her to lose weight for. And so I had a very honest discussion with her. I said, if you lose 10 pounds, are you going to feel good about your body? And she said, no. And I said, and if you lose 20 pounds, are you going to feel good about your body? And she said, no. And I said, well, then let's talk about the stigma of what our bodies are told to us that they should look like. And, she talked about her sister's been really skinny and her mom is really skinny, and she was always kind of the heavier one in her family. And we just unpacked kind of all this fat shame that she had collected through her life and put on herself. And it might not seem important, but feeling fat shame in yourself is a predictor of poorer outcomes. So working with these patients to kind of unpack that and get to realistic goals is really important. And she actually is working out. She gets her body fat percentage done. And now she's really proud of herself because now she has like a muscular goal and she doesn't care about her weight. So I really do think engaging these conversations at a little bit of a deeper level, especially if you have time and know your patient well, can be really powerful. And then this 38-year-old woman, I'd been following her for a few years, and then she decided to have a baby. And she came in after having the baby, and she was the one who told me, you know, I never cared about having a BMI of 44. I'm super active. I'm the director of the YMCA. Like, I work out every day. And she said, but now I have a baby and I really want to be healthy. And so we refocused on what did that mean for her, and is she having trouble getting around? Are workouts harder for her? And how can we make them easier for her? And again, not looking at a weight as a goal, but looking at functional goals of what does she want to be able to do better, and getting her to those goals instead of just kind of choosing a weight. So if you decide to tackle weight loss, the models that work the best are interdisciplinary care, having mental health, physical activity, nutrition, and medication and or surgery as part of this. I do warn my patients, especially at the beginning, this is at least a part-time job. I tell them you can't be really mad at yourself for failing if you didn't have enough time to put in a part-time job, because this is not easy. Food planning is not easy. Getting those workouts in is not easy. Many of us can't do it. So I put this slide in. This is just an intro to medication. Essentially, any medication works. Anything that the FDA has approved for weight loss works. And I have in the slides, and I put them in the slides really just to be more informative for you guys. You can keep the slides and use them as a reference if you want to. These are orlistat, lorcertin, and these are exactly like contraindications, common side effects. I'm not going to go through them all, but they're in the slides for you guys to read. Phentermine, topiramate, naltrexone, bupropion, and this is Saxenda. They didn't have the other GLP-1 agonists on this, but I do have them here. So this is the list of GLP-1 agonists. We're finding that it's more and more easy to get patients on these. I would warn, I think that sometimes these are very easy medications to prescribe and we know they're effective, so it feels really good to prescribe them. In the past year, I've had one patient have a pretty severe AKI because they stopped drinking water. So it's really important when we do prescribe some of these meds, because they can cause nausea and they cause people not to want to eat, that we still talk about protein intake and fluid intake. Because I've seen both of those issues come up where I've had a patient get protein malnourished because they just weren't taking the protein that they needed to. And I had a patient with an AKI that we had to stop the medication because they weren't drinking enough liquids. So these medications in a vacuum without the appropriate dietary counseling and follow-up are still not very useful. The most important thing I talk to patients about is anytime I start these meds, oftentimes we stop them, and when we stop them, they will gain their weight back. Many of these are metabolically active and help change somebody's metabolism, or they really greatly decrease their appetite, both of which will just revert back to normal in the absence of that medication there. So there's this one study that showed a year after stopping Saxenda, patients on average had regained 2/3 of the weight they had lost. So the medication either needs to be a long-term commitment and should always be paired with continuous engagement in increasing physical activity and healthy diet. So there's no easy way out. The other thing that I mentioned here is just surgery, and here I mentioned the gastric sleeve. This will greatly slow weight regain. We still do see weight regain, but it's usually like a decade or 2 decades after surgery. It's much more durable weight loss. It still needs maintenance, and many people need medication or other types of therapies to help them continue to have that weight loss. And really, again, patients who get surgery and then disappear have risks of vitamin deficiencies, weight regain, having leaks in their belly and other complications. So maintaining engagement with a physician, nutrition, physical activity, none of these are like one-hit wonders that you just do one thing and then you never have to look back. And this is, I think, probably the most important piece for me, because I'm a public health person first, before I went to medical school, is that this is really a pediatric epidemic. If kids can be normal weights through adolescence, their risk of having long-term obesity as an adult is much less. 1/5 of kindergartners at this point are overweight or obese. This predicts adolescent obesity, which is a predictor of adult obesity and morbidity. Obesity in childhood and adolescence greatly reduces the ability to maintain weight loss in adulthood. Again, looking at metabolism disorders, once you are obese, you will have a slower metabolism. And these patients will struggle with it for forever. You know, I had 2 patients that were friends, and one had been obese for a long time, and one had been skinny most of their life, gained like 30 pounds during the pandemic, and then she lost it. And she was saying, well, you know, I got my weight off. And I'm like, yes, because you have been thin most of your life. So you haven't struggled with that slower metabolism that's already slowing you down. So it is very different based on somebody's history about whether or not they'll be able to reach those goals more quickly and maintain them for longer. While childhood and adolescent obesity are strong predictors of adult obesity, most adults with obesity were not obese as children. And that, I mean, mathematically, it makes sense, right? Childhood obesity is around 20%, where adult obesity is around 50%. So we still are doubling our obese rates in adulthood. Interestingly, the AAP article on this showed that literally every year there's an increase in obesity in childhood. So starting at kindergarten, 1st grade, 2nd grade, it just climbs the whole time. The risk factors, again, are socioeconomic status, maternal job hours, which I think about a lot, being and interestingly, smaller family size. There's something about having multiple kids that makes them more active, and they have more people to play with. The foods that are at home, the drinks that are at home, and TV and screen time. So I always feel bad for my pediatric colleagues because I feel like they are just fighting an uphill battle. And then I put my slide before questions is like, if I could dream up something to really tackle the epidemic of obesity, would be, you know, we know that 150 minutes of physical activity are very protective for children in terms of developing obesity. And I wish that they would just have it in schools. I wish that the whole 150 minutes would just be within the school system. And so that we wouldn't depend on such big socioeconomic drivers of having kids be able to do those activities after schools. I would love to rework our WIC program to include nutrition, access to fresh fruits and vegetables, and cooking courses and cooking resources for families. I've had multiple families. I speak 4 languages, so I get a lot of families that don't speak English as a first language, and then they bring me the fruits and vegetables that they get, and they're like, I have no idea what to do with this. I've never seen this fruit or vegetable. I don't know how to cook it. And so I think there's a lot of good intentions, and sometimes we just don't actually give the patients the tools that they might need to be able to use what we give them. And then these are dreams. I put in here living wages so that parents can be more present at home, because that's a big protective factor for childhood obesity and child health. And I just wish more families could have dinner together at the table and more time in the afternoon together. So I realized I probably spoke way too quickly, and I'm just going to open it for questions if anybody has questions or comments.
Thank you so much for speaking tonight. This is such an important topic for us all to know more about, as weight loss medications have become super popular, especially in social media. So this was very informative. I hope we can take your ideas and apply them into our own practices. If anyone has any questions, please feel free to type them into the Q&A box at the bottom of your screens, the chat box, or unmute yourself and ask your questions.
I didn't include it in here, but there was some studies on, this is really all over social media right now, the glucose monitors that people are starting to use for fun, the ones that you put under your arm, the continuous glucose monitors. And there's no effect on weight loss in using those outside of in diabetes. So there's really no evidence to prescribe them more largely. And those studies show something that I think we all knew, those of us who treat diabetes, that people are very unique in their response to foods. So patients without diabetes will have like really fluctuating blood sugars, and patients with diabetes will react differently to different foods. So again, the idea that not one diet is going to work for everybody, and that people have very specific needs.
How do you handle patients who don't necessarily think that they have a problem with their weight, but you think do?
So I don't think that people have a problem with their weight unless they do. Like, I would say that outside of talking about it as a risk factor, like let's say I have to operate on somebody. So I do like tubal ligations and C-sections. And we know that, just like smoking, we know that wound dehiscence and wound infections are more common in people with specific BMIs or higher. And specifically, not just BMIs, but where they hold their weight. If somebody has a large pannus, they're at a larger risk of wound dehiscence, larger risk of infections. And I will just say it like that. In my consent process, I'll be like, this will give you a higher risk of this. This will give you a higher risk of that. And I just, I give them the information. But I try never to bring up weight when somebody doesn't want to talk about their weight. I do have, and this was on NPR the other day. Somebody was talking about Lizzo, and somebody said that they thought she was doing a disservice by promoting heavy body positivity, because now kids will think it's okay to be overweight. And I do have younger children who don't care about their weight at all. And I do their labs, and if all of their labs are totally normal and they're active, I leave it at that, and I don't care about their weight. I only care about their weight as a predictor of their health outcomes. And if they're doing everything to make sure their health outcomes are still good, then there's actually no predictive value of just the weight. Yeah.
Okay,
it is hard. I think that we are so trained again that fat is bad. It is in our head, and we have justified it to make it a health issue. Yet a health issue that you can make go away with exercise, yet it still exists. They're still the same weight, but even if they exercise, those health issues attenuate. Weight is not the biggest issue in the room. That's not what it is. If you look at Americans, and it's a chicken and an egg, right? If we are sedentary, we're going to be more obese. And if we fix the sedentary, we fix the cardiovascular health, and we fix the mortality benefit, but we're still obese. And in an ideal world, because surgical risk is always higher with people with obesity, in a perfect world, you wouldn't have become sedentary at all. And I think that that's something that needs cultural change. but I wouldn't blame that on any patient.
Okay, if anyone has any further questions, feel free to unmute yourself and ask. We'll stay on for about another minute or so. And thank you to everyone for joining us tonight.
And these are the references. It's a long list. It's a very hot topic right now. Yeah, I think also of, when we talk about health outcomes based on socioeconomic status, that causes a lot of stress. And obesity, being obese in the world, can cause a lot of stress.
Right.
And again, how your metabolism changes just based on the stress you're under it's all fascinating. It all kind of feeds into itself.
Okay, thank you so much for speaking tonight. I personally found it so interesting and I learned a lot.
You're welcome. I'm happy to talk to anybody. If your school wants me to do it, I'll do it. If you have a group that wants to hear about it, I'm happy to talk about it.
Great.
Thank you guys for inviting me. Good luck on school starts, all of the moms out there. We start school tomorrow over here.
All right, have a good night, everyone.
Good night.